webcasting, I'll let you know, then you can call the meeting to order.
Please, thank you.
Okay. We are good. You can call the meeting to order when you're ready.
Yeah, 1 minute, just to be exact.
Okay.
All right, it's 9 a.m. So I'd like to call the meeting to order. So Sarah, and the next item on the agenda is the public comment. Just to remind anyone who is planning to speak during the public comment, north to south, the comment limit is 3 minutes. We'd appreciate they would respect that in the interest of time for everybody. So anybody there in the north for public comment that has signed up? Sarah?
So let me just see if anybody wants to raise their hand to speak in public comment. This is the time to do so. Go ahead. If you are joining us via Zoom, raise your hand. If you are.
The other item is the comments need on the agenda. That's also the key.
Yes. And let's see, if you are joining us via Zoom, you want to go ahead and raise your hand.
Wait, shouldn't we call roll call first?
Oh, yes, you're right. Sorry.
Ready?
Sure. Chair Khan,
Okay.
actually, I think we need to go back to roll call.
Okay, I'll start with our voting commissioners.
Hold on
Good morning.
Well, 1 second. Let's see. Chair Khan, are you there? I just want to make sure he's still with us. So let's give it a moment for Chair Khan to rejoin the meeting. It looks like there were some technical issues.
Morning, Sarah. This is Mason. Can you hear me okay?
I can. Welcome. Good morning.
Morning.
So we are just, we still haven't called the meeting to order just yet. Chair Khan looks like he's having some technical issues, so we're waiting for him to rejoin us. Hey, Chair Khan, I can see you.
Okay, so
Oh.
now I can hear you. I don't know what happened.
Okay, that's okay. It's good to have you back. So we were at Leslie's was ready to call roll. If that's good with you, we'll have her.
Sound is coming interrupted. Anyway, go ahead. Okay,
Okay. Good morning. Are you ready?
fine, please.
Okay.
Chair
Khan?
Somehow there's technology issues.
Yes, and one moment, Chair Khan, if you don't mind, maybe with your connectivity, if you could turn
Yes.
off your video, that actually might help a little so we can hear you, but maybe your video is what seems to be glitching, at least on my end.
Okay, so I turned the video off. Can you guys hear me?
Yes.
Yes. Okay, to continue,
Okay, so please proceed.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Bobette Bond,
Here.
Jessica Flood,
Here.
Dr. Packham,
Here.
Yarleni Roa Dugan,
Here.
Sean Shaner,
Here.
Dr. Slonim,
Here.
Mason Van Howling.
Here. Good morning.
Good morning. Moving on to our advisory commission members, Heather Korbulik. Heather here?
She is.
I'm
Oh,
here.
there she is. Okay. Barbara Richardson,
Here.
Richard Whitley.
Here.
Okay, and Flo Khan will be joining us a little later. But Mr. Chairman, that concludes our roll call and we have a quorum.
Okay, thank you very much. So I guess we were going to talk about public comment, right? Is that
Yeah.
where we went off?
Yes.
So do we have anybody in the North, Sarah, for public comment? Just a reminder again, 3 minutes time limit for each presenter.
Okay. So if you're joining us via Zoom, if you can at this time, go ahead and raise your hand. If you're joining us via the telephone, please press *9 to indicate that you'd like to speak and we'll allow you in. Right now we have one person in the queue, Mr. Jesse Wadhams. I'm going to enter you into the meeting.
Good morning. Hopefully you can all hear me. This is Jesse Wadhams. I'm here today representing the Nevada Hospital Association. Wanted just to take a quick moment to acknowledge all the work that this commission has been doing, especially important in this pandemic. Now it appears obviously that the pre-filed bills are out and the commission's bill drafts have been codified into SB 5 and SB 40, if I'm not mistaken. When we're looking forward to hearing that review of that language of those bills, obviously, as we all know, sometimes what goes into LCB doesn't come out exactly as one had originally intended. So that walkthrough and preparation of any conceptual amendments, if they're needed, is always probably a best practice. So looking forward to hearing that discussion either later on this agenda or on a future agenda. With that, that's it.
Thank you, appreciate it. Anybody else, even in South?
I do not have anybody. Let's just give it one more moment. Mr. Chair, it looks like that concludes public comment. Looks like we don't have anyone else that's wishing to speak in public comment.
Thank you, Sarah. So the next item on the agenda is presentation from patients about their health care experience in Nevada. Sarah?
Yep. And so commissioners, if you recall, this is a standing agenda item that we have that gives an opportunity for patients to submit testimony or come in front of this commission to share their stories. We uploaded a patient tab on our website that allows them to submit their stories electronically. At this time, it looks like we're still new. We haven't received any, but again, for everybody who's watching and participating, I encourage you to take an opportunity to come in front of this commission, tell us your experience with healthcare, share your story. And if we missed you today, please visit our website at ppc.nv.gov and consider sharing your story through that portal.
Thank you. We have item number 4 for action, approval of November 9th, 2020 minutes. Do I have a motion to approve the minutes if you have had a chance to go through them?
Motion to approve.
This is Tony, I second.
Thank you. Any opposed? None, motion carries. Next one, open remarks by the chair. I really don't have much. We would like to get this meeting concluded, hopefully by 12 noon. There's also a hard stop for Sarah. She has a meeting to get to. So we will go through our usual process. There are some presentations that materials were sent to all the commissioners as I received them and Sarah sent it to everybody. Hopefully everybody got them and got some sense of what's being presented. So before we go to the presenters, I would appreciate if they could limit their presentation as they've been advised by Sarah to 15 minutes, because following that, we'll be having all the commissioners have the opportunity, as always, in sequence, so that everybody has a chance to ask questions and get some answers and go from there. So having said that, we can go to the next item, presentation of Nevada current status of health insurance enrollment numbers and future challenges by Heather Corbulic, Executive Director, Silver State Health Insurance Exchange. Is Heather online?
I am, thank you.
All right, please go ahead, Heather. Thank you.
Okay, I need to share my screen for this, so if everybody can give me just a minute. Oh, I think you've disabled me, Sarah, to screen share.
Oh, hold on. Okay, I think you should be good now.
Okay, let's see. Okay.
We have you on the screen.
Okay, there we go.
Great. So I assume everyone can hear me just fine. Nod your heads. Okay, thank you. All right. So again, my name is Heather Corbulic. I'm the Executive Director of the Silver State Health Insurance Exchange, the state agency that runs and operates the online marketplace known as Nevada Health Link. Sarah asked me to kind of not redo, but kind of present more information for you all on sort of the challenges that the exchange is facing this open enrollment period. So I don't intend to spend much time on this slide, and we can move to the next. Just a quick picture of where we've been in terms of enrollment year over year. We started at the 2014 year. That was an interesting year. And we've gone up to a high of 91,000 in 2018. We're sitting at about 77,000 for 2020, and we'll see what happens for 2021. We're intending to put our first numbers out for the first 30 days of open enrollment tomorrow. Okay, next slide. And just a quick reminder, this year, open enrollment 2021, we have double the plans from previous years. So we have 50 qualified health plans. We have 3 returning carriers with Health Plan of Nevada, Silver Summit, and Anthem. We also have 2 new carriers, Friday Health Plans and Select Health. And Friday is a statewide carrier, meaning they're in all 4 of our rating areas, and every county can select from the Friday Health Plans. Select Health is just in Clark and Nye County. We have, of course, the 4 different metal levels: catastrophic, bronze, silver, and gold. And then we also have 21 qualified dental plans with 6 different dental carriers. This is the first year that Nevada HealthLink has been able to work with a vision carrier, and we're very excited about that. So enrollees will be offered an opportunity to look at vision plans through VSP. We have extended our open enrollment period. So it started November 1st and it runs through January 15th. It is important for me to say in this meeting that anyone who enrolls by December 31st, so a month from now, will have January 1st start date. And anyone who enrolls between January 1st and the 15th will have a February 1st start. The final rate changes for on exchange was 4.2% increase, which is pretty minimal considering all of the varying factors that went into this year. But what we do know is that over 80% of the consumers on the exchange, so 4 out of every 5 consumers, have subsidy assistance. So they will likely see very little, if any, impact of that rate increase. We have 8 different navigator entities, and we have 5 broker grantees that we give money to help with enrollment and with promotion and outreach. Okay, next slide. So this is really the meat of what I was hoping to talk with you all about. There are lots of challenges for open enrollment 2021, but I should preface this whole thing by saying that I've been with the exchange for 5 years, and we have never had a drama or trauma-free open enrollment. So the changes are different every year. This one, I would say, is compounded by, of course, what everything is being compounded by, which is a pandemic. So we are absolutely looking at a variety of different challenges and unknowns. The first, of course, being that there is a pandemic and we're a business struggling with how to do our business in this remote landscape. Previously, we did a lot of our outreach in person and at community events. We've had to really restructure and change the way that we're doing our outreach. We've also had to be careful and mindful about the way that we promote and advertise. Really this year speaking to the fact that COVID-19 is happening and really looking at, kind of picturing the moment. So a lot of our advertisements, which hopefully some of you have seen, have advertisements with people wearing masks, talking about their pre-existing conditions and about why they're getting coverage. So we also have had to shift the way that we do open enrollment. And so we've made sure that the over 700 different brokers and navigators that work with the exchange have the ability to do telephonic or virtual enrollments. Some of them are doing in-person events, but of course are following CDC guidance while they're doing that. The other challenge of COVID was the fact that we needed to be responsive to a pandemic. And so thankfully, because the state has chosen to be an autonomous state-based exchange, we were able to implement our own special enrollment period back in March that ran through May. That was primarily targeting anybody who was uninsured and gave them a special enrollment period to get insured during that time. And during that time, we saw about 6,000 enrollments. The other elephant in the room, I guess, is the constant and ongoing discussion of the Affordable Care Act's repeal. This year has been a little bit different than years past, where I think that this is probably the second closest we've ever been to a full-on repeal. The first time being when John McCain infamously put his thumb down on the Senate floor, and that was an interesting night on C-SPAN, if you can believe it. And this year is another interesting dynamic with the Supreme Court hearing the repeal case on November 10th. I will say, and I've said in several interviews, that I feel pretty confident about the resiliency of the Affordable Care Act. But the noise and the confusion that's created because of a Supreme Court hearing and even more and further discussion about a repeal can be pretty damaging and creates more of a need for the exchange to reduce the noise and focus people on getting coverage for 2021. The other thing that is huge is that we're in an election year, and while the presidential election is over, the Senate races are not. And what happens with the Senate races in Georgia on January 5th will have a pretty dramatic impact on what the future of the Affordable Care Act looks like and what the future of healthcare in general looks like. I think if the Republicans remain in control of the Senate, then we will probably end up looking at making policy fixes through more of an executive branch, an executive policymaking perspective. Should the Dems take the majority, then we'll be probably having much more substantial conversations about legislation and either improving the Affordable Care Act, adding on to the Affordable Care Act, and potentially even looking at some public options. The kind of pressing and interesting dynamic of 2020 has been the significant change in our employment rates. As many of you know, I spent some time at Dieter this summer, this early spring and summer, and know quite a bit about what that impact looks like on Nevada. And unfortunately, the dynamic isn't just the fact that people are losing their employment and their wages, it's also that they're losing access to their employer-sponsored coverage. So we're seeing a real shift from people moving from what's known as ESI or employer-sponsored insurance to the private market, which is on exchange and onto Medicaid. One of the things that's been problematic and hard to communicate to people this open enrollment and during the last special enrollment period throughout this year is that if you're collecting unemployment benefits and you're getting those federal pandemic unemployment compensation wages, or in the future, the lost wages, the way that the feds have written the rules is that you must count those two wages as income. When you're applying for the exchange. However, if you're applying for Medicaid, you don't have to apply or don't have to count those as income. So it's a confusing dynamic that's created kind of a difficulty in making sure that people are selecting the right income threshold so that they don't end up having to pay the IRS come January. The other very interesting dynamic that I'm working closely with the Division of Welfare and Supportive Services and the Division of Healthcare Finance and Policy, or Medicaid, is the redeterminations of Medicaid. So the Families First Act requires that states hold on any Medicaid redeterminations. And as many of you are probably aware, we saw, I think, 16% increase in Medicaid enrollment over the last several months. So what that means is that many, many, many thousands of people have got Medicaid benefits, but are not being redetermined as they usually are on an annual basis. So once we start processing those Medicaid redeterminations, which is looking to be around the month of March, we will start to see a real shift again in where people are going. So people who have gone back to work, who are potentially having or have more income now, may find themselves being terminated from Medicaid because they have now exceeded the minimum or the maximum income threshold and will now be eligible for the exchange. So we're really trying to position ourselves to manage that churn, which we know will be much more than it has ever been in years past, and capturing people and making sure that they stay insured and don't lose benefits, because it's, of course, a critically important time to have health insurance. And then finally, the other thing that we always deal with, but I would say I've seen a much more aggressive campaign this year, and it's frustrating to say the least, is we see these marketed or these aggressively marketed competing plans. And I put plans in parentheses here because, or excuse me, in quotation marks here, because These plans are not generally as comprehensive nor generous, and in fact are misleading people into believing that they're purchasing Affordable Care Act comprehensive insurance when in fact they are not. So we see that a significant number of Nevadans are getting robocalled about health insurance or just cold text messages. And oftentimes those folks are being sold indemnity plans, health sharing ministry plans, and short-term limited duration plans, none of which are long-term options, nor are they comprehensive, and nor are they generous. And so these are all the types of plans that once they determine you have a pre-existing condition are able to drop you or will not have to cover the care that you are potentially in need of. And then lastly, next slide, I just want to remind everybody, because you are all healthcare stewards in the state, and I would really appreciate your assistance in making your connections or your organizations to help us get the word out that open enrollment is current and actively happening, and that we are available 7 days a week throughout the open enrollment period, and we would appreciate your support in getting that word out. And with that, I'm happy to take any questions.
Thank you, Heather. Appreciate it. Sarah, back to you. Can we follow up our procedures to make sure every commissioner is identified and move on so that everybody can have their questions?
Or do you want me to do a round table kind of roll call to let everybody ask a question?
Yes, yes, please.
Sure. So Commissioner Bohannon, do you have any questions for Director Korbulik?
I do. Thank you. Thank you for the presentation. I was curious if you could provide kind of a rundown of what's the average cost and deductible and out-of-pocket costs are for the consumer. Just for fun, I went onto the exchange to look, and I was quite shocked at what a plan for myself would cost. And I don't think that it was affordable at all. I think I saw about a $13,000 deductible. And I'm not sure if that's average or if there was just something I was doing that wasn't correct. But I'm just curious if that's what a lot of consumers are facing, are really, really high deductibles.
Heather, you have the answer?
I can absolutely get you the numbers for 2021. I don't have that available to me right now. One of the things that may have happened, Commissioner Bohannon, is that when you're searching and you're doing the anonymous search, you of course have to put your zip code in, which helps connect you to the rating area. But then when you're filling in your income, depending on where you are in income range, so if you're under the federal poverty level of 400%, then you're eligible for subsidies, and you may not have seen those subsidies because you entered an income that was exceeding that threshold. And so what I will say is that one of the most hardships of people in the state, and where we suspect that many people who are eligible to get exchange coverage are falling short, is that they are falling off the subsidy cliff. They're over 400% of the federal poverty level and are therefore required to pay the full freight cost of health insurance, which, yes, you're right, it is expensive, and the deductibles are high. And so, yeah, without having subsidy assistance, insurance can be completely expensive and prohibitively so.
So Heather, could you send a tabulated form of those ranges to the commissioner?
Yeah, I will get you guys averages for 2020.
Yeah, that would be helpful to give us some idea where the overall picture is. All right, thank you. Does next commissioner have a question online, Heather? Oh, sorry, Sarah?
Okay, Commissioner Roa-Dugan?
No, I do not have a question, but I would like to thank Heather for the information.
Thank you.
Commissioner Flood?
The commissioner online or muted?
Yeah, we can. I'll go back to her. And I don't believe Commissioner Khan is on as well. So Commissioner Shaner.
Thanks. One question real quick, Heather. You mentioned that tomorrow some information will be released on the first 30 days. What fields would be included in that? level, not asking for specific numbers, but what kind of information?
We'll release the first 30 days of open enrollment, of enrollment. And so that will include new enrollments and active re-enrollments. So people who have taken action, and then the number of folks who were automatically re-enrolled.
Thank you.
Thank you. Next, Commissioner Sarah.
Commissioner Bond?
Thank you, Ms. Skrbulak. It was really helpful to hear that. My general reaction is this churning issue. We've talked a little bit to DHHS about it and tried to figure out solutions, over time. We have a lot of members in the Culinary Health Fund that lost eligibility at the end of October. And most of them, we're learning, are not Medicaid eligible. So it's interesting to see sort of how this might play out. But I think I would like us to have an overarching conversation about how people stay in their own plan and have that avoid the churn by having the ability to stay in Culinary Health Fund over time. I know we've talked to Medicaid about options. We've tried to do that in the past in Nevada, and I think nationally it would be really helpful to try to figure out how not to move people at all and let resources follow the belly button. And I know that's not how the ACA was set up, but it is a good conversation to have about how to fill gaps in the future. Thank you for the information.
I'm totally game to have that conversation.
So could you share with the Commissioner, Heather, offline, if that's appropriate?
Sure, we can talk. I'm happy to talk with you, Commissioner Bond, about what we are currently doing and how we've, I will say, it kind of exceeded the baseline of churn management that healthcare.gov had as our own state-based exchange. We have improved upon that, but there are lots of ways in which we could further improve. I think it's going to take some real policy lifting to get people to stay in their existing plans, but that's certainly something I'd love to have a conversation about.
Okay, let's do that. That would be great for us too. Appreciate it. Thank you for the information today.
Thank you. Sarah?
Yep, Commissioner Van Houweling.
Hi, good morning, and nice job as always, Heather. I just was curious on the 18 peaks to now. Obviously, we're dealing with a unique situation in 2020, but was some of the declines related to an improved economy, or people just less qualified, or was it because of some of the enforcements of the IRS tax code related to mandated insurance? And then if you could send me any marketing material electronically, we'll blast it out on we do that every year on our UMC page. So we'll get it in our quick cares and primary care offices.
I am right on top of that. I will get it to all the commissioners. Thank you. Yeah, so you're absolutely right in your assessment of kind of what's gone on between 2018 and 2020, but it's very hard for me to pinpoint any one reason, but because so much is always happening in this space. But yes, the loss of the individual mandate certainly probably played a role, but we also saw some flexibility and some increased sort of weakening of the Affordable Care Act through policy making during the last couple of years that has really allowed for like short-term duration, limited duration plans and sort of these other actors to be a little bit more robust and aggressive. And so I think we've seen shifts where that's concerned. I think we did see an improved economy, and we may have seen people transitioning into employer-sponsored insurance during that time. There's just so many different factors.
And one other follow-up question, if you don't mind, in aligns with Commissioner Bond's comments, and as my assessment, at least in the economy down here in Southern Nevada, a lot of the employers on that first wave at stay-at-home tried to keep their employees as whole as possible, whether it's extending out their salaries, their tips, their wages, their insurance. My conversations with some of the executives is that it's just not sustainable this go around, especially as we progress with the positivity rate and the hospitalizations here. So I definitely think that there will be more renewed interest in your organization, and we'll do whatever we can to help support it, as long as the funding's there as well and the subsidy dollars.
Thank you. And just a reminder that we have so many people, insurance is really confusing, especially if you've fallen off your employer-sponsored insurance and you're navigating a new landscape. So that's why we always encourage people to work with our licensed professionals. Make sure you're getting connected to Nevada Health Link and finding somebody who can help you through the process. So thank you for allowing me that moment to say that.
Thank you. Sarah, next commissioner online.
Sure, let's go back to Commissioner Flood. Commissioner Flood, do you have any questions?
No, I just, my concerns really are reflected in what Commissioner Bond and Bonahan said as well, especially with the churn. And if you do set up that meeting, I was wondering if maybe we could have it where multiple commissioners participate. Thanks.
Thank you.
Sure. Okay.
Who's next?
Commissioner Slonim, Dr. Slonim?
No, thank you, Heather. Appreciate the report. No questions.
Thank you.
Commissioner Packham?
I have no questions. Thanks, Heather.
And Commissioner Barron?
Thanks, Heather. My question is more a speculative one maybe, but I'm sure you've thought about this quite a bit. There's been some discussion very superficially in past meetings about a public option, and should we be pursuing that in our state? And my question to you is, as director of the exchange, how do you see that fitting in with the exchange? How do you see something like that impacting the exchange, enrollment, et cetera?
That's, of course, I spent a lot of time thinking about that and have been working on the SCR 10 study that is currently being developed. And so I can say a few things. The first is that when you talk about a public option and you say, what do you think about a public option? People always want to know, what is a public option? Because they have so many different flavors. It's really hard to talk about a public option without having any kind of specifics and narrowing it down. And the research that we've done over the last several years and the conversations that the state has had about public options has really kind of focused on, let's say, expanding Medicaid, or let's say expanding the exchange eligibility, or whatever, or Medicare for all. There's all sorts of different public options discussions. And at a state level, I think we've demonstrated over and over again through actuarial analysis and discussion that it's really expensive to do something like that without federal support. Expanding the existing programs or benefits to people who are potentially currently uninsured really does come with a pretty hefty price tag. And in absence of federal support, I'm not sure that the state can afford to do something like that, especially in this current budget climate. And I would say that I think the exchange, looking at the Biden administration's plans for the next several years, depending on who wins the Senate, I think there is some really interesting and wonderful options that could have potentially really big consequences for Nevada. One of them being expanding the subsidy cap. So taking it from 400% of federal poverty up to maybe 600 or beyond, which offers an enormous amount of more Nevadans an opportunity to have subsidized insurance, which, as Director or Commissioner Bohannon pointed out, it's expensive if you don't have that subsidy. And then also talking about eliminating the family glitch, which has been a problem with the Affordable Care Act for 10 years. And then thinking through taking out the affordability and changing the affordability formula for people who are currently getting employer-sponsored coverage. I think that's a really interesting change and something worth discussing, because one of the things that the Affordable Care Act was designed to do, and which has really proven itself to be valuable over the last several months, is offer portability, to offer people a safety net of having access to insurance, comprehensive insurance, if they were to leave their job or lose their job. And I think that's what we're seeing right now. And the conversation about whether an employer-sponsored coverage is the way forward is definitely a policy discussion that I think is going to happen at a federal level, regardless of who wins the Senate.
Thank you very much, Heather. So did we include everybody in the question, Sarah?
Yes, we did.
All right. Thank you very much, Heather. Really appreciate your pretty informative discussion. There are several items you will be sharing with the commissioners offline ASAP so that their questions are answered. Thank you. Again, we go on to the next item, which is, where are we? Item number 7, presentation on comparative Medicaid reimbursement rates across states. Suzanne Bierman is here, the Administrator for Division of Healthcare Financing and Policy, DHHS. So I see you're on, your slides are up.
Great. Well, thank you for the opportunity to speak with you all this morning. I'm Suzanne Bierman, the Administrator for the Division of Healthcare Financing and Policy, and going to spend just a little bit of time this morning talking about Nevada Medicaid reimbursement rates and to the extent that we have information about how those rates compare across states. Next slide, please. Okay, I've included 2 slides here just for some context. Don't want to spend a lot of time on it, and we'll flag that both of these slides are from 2019. And as Heather mentioned, and as I discussed last time, certainly have seen shifts in these numbers due to the COVID pandemic, but just wanted to put a little bit of context around this conversation and just spend a little bit of time looking at the sources of insurance coverage in Nevada. And I have 2 slides, one that show ages 0 to 65, and then one all ages to kind of show the differences once Medicare is included here. And as you can see here, in 2019, about 58% of Nevadans had employer-sponsored insurance. And at that time, about 20% were on Medicaid, and Nevada had an uninsured rate of about 14%. And again, that is for the non-elderly ages 0 to 65 population. Next slide, please. Okay, so this is all ages, and you can see how Medicare plays here. You know, primary source of insurance coverage for Nevadans above 65 and older. So just wanted to show that and provide a little bit of context. And also, as I talked about last week, you know, certainly we've seen significant increases in Nevada's Medicaid enrollment, as Heather mentioned, decreases in employer-sponsored insurance, and a 17% increase in Nevada's Medicaid enrollment since February of 2020. Said before, Medicaid was covering about 20% of the population. It's now up to 25%. So certainly these numbers have changed and are in flux due to COVID, but did just want to provide some additional context around Medicaid and overall insurance coverage in Nevada before we jump right into a discussion of reimbursement rates. So next slide, please. Okay. Well, I wanted to spend a little bit of time talking about Medicaid's rates, and there are many of them, and it is a complicated and complex topic. We have right now 290,000 active reimbursement rates. So, you know, talking about reimbursement rates, there are a lot of rates there. We have a little more than 38,000 enrolled providers in the program and 64 provider types that have numerous specialties that get us up to that 290,000 reimbursement rate number. So we do have some information here on how we set rates for the fee-for-service program, and there are a variety of different rates and rate methodologies that we use in the program. Some are based on a fee schedule, compared to Medicare fee schedules and use relative value units and location adjustments. Others are cost-based. We have some prospective payment system rates for services like federally qualified health centers that are based on cost report data. And then we also have some negotiated rates that we use in the cases of out-of-state providers or specialized care. So again, just wanted to spend a little bit of time focusing on the fact that this isn't, monolithic. There is nuance and complexity here, and Nevada does pay for a lot of different reimbursement rates and types. So Next slide, please. Okay, so we do have an entire unit within the division that focuses on rate analysis and development, and they are known as the Rate Analysis and Development Unit, or RAD, which may be my favorite Medicaid acronym. So the RAD unit does develop rates, does rate studies, reviews, rate appeals, and is also responsible for analysis that is needed by the Centers for Medicare and Medicaid Services when we seek to change our Medicaid reimbursement rates. And that process does require state plan amendments, and a lot of detailed work goes into setting and changing Medicaid's reimbursement rates. All of that is outlined in our state plan, and you have the links here to the reimbursement sections of the state plan and our Medicaid services manual that outlines the rates policy. Next slide, please. Okay, so I talked a little bit about how we set rates in Nevada Medicaid. I know the desire for this presentation was a comparative review of how those rates compare. Again, it's kind of hard to make large-scale generalizations given the number of different rates. So did look through the national literature, and this seems to be the most often cited study. It is from the Kaiser Family Foundation, and it does have some limitations. It's a little dated at this point. It's from 2016. This particular slide is for physician services. So not all services are, not all 290,000 rates are captured here by any stretch of the imagination, but it does provide a high-level national roll-up that measures each state's physician fees relative to Medicare fees in each state. And as you can see here, Nevada ranks the 6th highest overall and 13th for primary care, 6th highest in the nation for all services, 6th for primary care, and 13th for OB care. So did just want to provide some national high-level comparison information. I mean, I will say to you as a general concept, of course, commercial rates are higher than Medicare, and Medicare is higher than Medicaid generally, and you know, then there's uninsured and uncompensated care. So did just want to provide some high-level information on where Nevada's Medicaid rates compare to other state Medicaid rates relative to Medicare payments, and this again seems to be the source that's most often cited, and that's available here from the Kaiser Family Foundation. Next slide, please. Okay, so in addition to that information, there have been a number of legislative efforts to better understand Medicaid's reimbursement rates in Nevada and how those compare to other states. And so in the 2017 legislative session, Assembly Bill 108 passed, which requires the division to review all rates every 4 years. So again, we have a lot of active rates, and we have a process for doing this. The schedule of reviews is online, and the link is here. I will say that we put out our first of these reviews earlier this year in March for a handful of provider types. We can certainly make that report available to the committee, but is a massive undertaking and is proceeding according to this schedule that's developed and linked here. So next slide, please. Okay, I did also want to spend just a little bit of time talking about AB 116, which was proposed but didn't pass in 2019, which I think also got to a desire of better understanding all the nuance and how Nevada Medicaid's reimbursement rates compare to other rates, including Medicare. So the division and our RAD unit did do some preliminary analysis in response to legislative request in 2018. It certainly wasn't comprehensive and didn't include all of the rates, but it was you know, a first start in terms of trying to quantify some of the increases that would be needed to get Medicaid reimbursement rates up to Medicare. What we learned in going through that process is that it was a pretty complicated analysis, and further actuarial studies would be needed to fully develop a complete understanding of that fiscal impact of aligning Medicaid and Medicare rates. But as you can see, just based on a not fully complete analysis, it would require a significant additional investment of non-federal funds and general fund appropriations to align Medicaid to Medicare rates. And again, kind of putting that into context with that Kaiser chart. So did want to mention that there has been interest in studying this. The study wasn't funded, and AB 116 ultimately didn't make it through in the 2019 legislative session, but some work was done on this and have linked here to a memo for anyone that is interested in digging into a little bit of those details. But I think the big takeaway is that yes, generally Medicaid pays less than Medicare, and even aligning those two rates would require a significant additional investment of general fund appropriations. So just did want to note that that study has happened and provide the link to that resource. Next slide, please. Okay, well, I'm happy to try to address any questions that you all have. I will say that I did invite Medicaid's actuarial economist who works closely with our RAD, or Rate Analysis and Development unit, to assist if there are technical questions. So with that, I'm happy to chat further and see if we can address any questions that the committee has.
So Sarah, I have a question. Sorry, I use the chair's the prerogative to ask the question first. But having said that, you talked about the rates and the comparison with Medicare, etc. Are these the rates you're talking about for Medicaid fee for service, which is a very small fraction, or these rates are also sort of controlled or managed or guided by the state for all managed Medicaid products, which is the larger or significantly larger share of Medicaid in the state, vis-a-vis the reimbursement through managed Medicaid to physician providers and hospital providers of service? Are those rates similar to Medicaid fee for service, and how lower than the Medicare rates are these rates from managed Medicaid?
Yeah, great question. Thank you for that. Yes, you're right. About 75% of our enrollees are currently enrolled in managed care, and largely these studies are based on the fee-for-service rates. And that was to the point of we would need additional actuarial studies to more fully understand the full impact. And managed care rates are influenced by the fee-for-service rates. Many of them are largely based on what is in the fee-for-service schedule, but they're not the same. And that additional level of actuarial analysis for the managed care comparison, we haven't completed, and would need additional resources to contract with an actuary to be able to more fully address that question.
So the reason I asked this is because I'd also brought this to the attention of the previous governor and this governor, is the reimbursement rates for the hospitals and extended care facilities, nursing home, etc., are so low, as I'm told, that nobody wants, other than hospitals, they don't have a choice from the emergency room, but the extended care facilities, they do not want to take Medicaid patients because their argument, right or wrong, is that the reimbursement is so low that they'll take a Medicare patient right away, but not a Medicaid. Is that realistically true in your assessment?
Well, I mean, I think that there are access issues in Nevada generally. We've talked a lot about provider workforce issues, and really the standard for Medicaid is that the access is the same as what is otherwise available in the community. And any changes to our rates that are made have to be approved by the Centers for Medicare and Medicaid Services, and that is the standard that they used. It's in the Social Security Act, Section 1902A38 is really the standard. So anytime we make changes or seek to make changes to our reimbursement rates, it has to go to CMS for approval. And that is part of their process, is making sure that the services are available in the community to the same extent that they are for the general population. So we are working through that process with CMS right now. Are Medicaid rates lower? Yes, and I think, you know, as a general matter, and I think the data presented today shows that, and I think that's true across states. Again, there are some exceptions where that doesn't hold, but as a general rule, yes, Medicaid rates tend to be lower than Medicare, which are lower generally than commercial rates. But we do have a process that we go through with the federal government to ensure that Medicaid enrollees are able to access services, and we'll acknowledge that some of our rates are lower than others on a comparative basis, and happy to look into any particular rates, and also can let you know when particular rates like skilled nursing facilities, I think are one that you mentioned, can report back where that falls on our quadrennial rate review required by AB 108.
Thank you, appreciate that. Leave the questions in this regard to our hospital representatives and providers and Dr. Barron. Please go ahead, Sarah, with your list.
Sure. Let's start back. Commissioner Bohannon.
Thank you. I don't really have a specific question. Thank you so much for the presentation. It was really informative. I guess I do sort of have a question of what would it take? Would it need to be a national, or could it happen on a state level to get to a place where we have automatic enrollment and an increase in presumptive eligibility, given the current economic crisis that we do find ourselves in?
So currently in the state plan, Nevada has hospital presumptive eligibility. There are states that have more robust presumptive eligibility programs. And so we have taken a look at some of those, leading into discussions with the interim health committee. So it really just, for the options that are available through CMS, it really requires a state plan amendment. So it could happen at the state level in terms of expanding presumptive eligibility beyond hospitals. And there are a number of different settings which CMS allows it in a more kind of robust presumptive eligibility program where FQHCs and others have access to the same sort of presumptive eligibilities that currently exist for hospitals.
So just as a follow-up, when you say hospital presumptive eligibility, is that a situation where you're uninsured and you find yourself in the ED, and then the social worker or something like that may come along and find that you would most likely qualify for Medicaid, even though you don't have Medicaid? But in other settings, like outpatient type settings, we don't have anything like that.
Right.
Correct.
Currently,
Okay.
it's just hospitals. But other states have a more robust array of providers that have presumptive eligibility programs.
All right, thank you. Next, Commissioner Sarah.
Commissioner Roa-Dugan.
Yes, thank you so much. I do have a question. I would like to know what is the difference between the Medicaid coverage and the Medicare, like how big of a gap there is between those two, as well as the reimbursement.
Thanks for the question. So I think it largely depends on which particular provider types we're talking about. Again, this Medicaid to Medicare fee index that's on slide 6 shows the overall national average and has some information for certain specialties. But again, there are limitations in the study. It is limited to physician fees. So if there are particular providers or provider types, we could look into that and also provide information on where that falls in the AB 108 studies. But I guess just due to the various number of providers we have, would need to look into the question specific to certain providers. So happy to do that if we want to follow up after the meeting. If there are certain provider types that you're interested in, we can let you know where they fall on the AB 108 schedule, and also if we have any current information that more specifically addresses that question.
Thank you so much.
Thank you. Our next commissioner online.
Commissioner Flood.
Yeah, thank you. That was a great presentation. I just have a few questions. So I was wondering, it looks like we have higher reimbursement rates, and if you look at the states around that, those probably have workforce issues as well. They're kind of like rural Western states. So it's probably why we have higher rates, I'd imagine.
I think that makes sense, especially when you look at Alaska as having the highest. So I think generally that holds and is kind of, some of the same conclusions that I drew, but I'm not sure that there's something I can point to that cites that, but I think that's reasonable.
Yeah, and so the trend is that Medicaid pays, some, but usually it's not quite enough. And then we have, I'd imagine all states kind of have that issue with trying to get providers to take Medicaid because it's never quite as much as you'd like it to be. There's been a lot of discussion in the rurals about having a higher rural rate for workforce. And I know that I've gotten different answers from the state on that. Sometimes it's like, oh, that's not legal, but then I've heard that there are workarounds. So I was just wondering if that's ever been contemplated, because it's such a small population out there. I don't know if that would take, I'd imagine if that you provided more access to care in the rural counties with like outpatient, you'd have less people visiting the ERs out there. Because I think that I just hear anecdotally people going to the ER for everything out there in the rural counties, probably because there aren't that many providers out there. So I just wonder if there's that cost benefit where we could actually save money by increasing rates.
I think that's a great question. And I'm a little bit familiar with what you've heard. Like, I think it's the general rule is that's not favored, but there might be some ways, some exceptions. So I can follow up with that. I know Deputy Administrator Dwayne Young has done some work on that particular issue. So I can follow up with him for the latest and get that information back to you.
Excellent. Yeah. And then just two more points. I read probably most of that Silver State Solutions report, and I saw that there is a recommendation to expand presumptive eligibility. In my experience, presumptive eligibility does not work because you're basically like, hey, we're going to presume eligibility, follow up with this. And a lot of people do not follow up with all of the documentation needed. But I guess that report was also saying that you can automatize a lot of that, like ensuring that all of what they're saying is actually true, right? So maybe those are the two pieces. If you expand presumptive eligibility and then try to automate some of that follow-up to make sure that they're actually eligible for it.
Yeah, I think that makes sense. And I mean, I've even heard on the hospital provider presumptive eligibility side that it's not perfect and, that the implementation is sometimes challenging. But I really think, when looking at all options to try to improve access and get our uninsured rates down, that it's one tool in the toolbox and probably not a silver bullet, but certainly something worth looking into and exploring and how you can streamline it and, make it as efficient as possible. And also just another option available to consumers to, make sure that they are insured if they qualify for Medicaid.
Right. Yeah. And I have to say that it also said that we should increase those DWSS, the worker outreach program, that there's like 52 needed throughout the state or who have been requested. And I have to say in my region, that was probably the most popular program that the state had. I mean, it like directly addressed the needs of the community. So I just wanted to highlight that. And then finally, it talked about addressing Medicaid suspension versus termination for people who are incarcerated. And from my understanding at the state, it's actually kind of a technological issue where you guys really need to do quite a bit on the database end to be able to have suspension instead of termination. I was just wondering if you have an update on that.
Yeah, well, I know there was legislation in the 2019 session and that DWSS has been in the process of working on that. If the technological solution that you mentioned, I can reach out to them to get an update as to where that is, but I think your framing of it is exactly correct and something that they've been working on since the last legislative session.
Great, thank you. Well, wonderful presentation.
Thank you, appreciate it, Sarah. Next commissioner.
Commissioner Flocon.
Thank you. I don't really have, and I apologize, I was late to the meeting. The only question I would have, and forgive me if you've already talked about this, is are there other incentives to attract providers outside of just the reimbursement rates, ease of use of system or other things that you've heard from from the providers, and I'd be interested if any of the providers on the call had any other things to add, but that you might have heard of that could be done to attract more into the Medicaid system?
Well, I think you raised a great point too, and we do sometimes hear about challenges with provider enrollment and credentialing and some of those things that go along with being a health insurance provider, and always happy to look for ways to administratively streamline some of those things that can be a burden. And I think at the federal level, there's been a lot of interest in exploring some of those things, but certainly happy to hear from providers or others if there are things that aren't related to reimbursement rates that we can do to help improve the system, or in addition to.
Thank you. Next commissioner.
Commissioner Shaner.
Thank you very much, Suzanne. I appreciate the presentation. It was interesting to see where Nevada ranks relative to the other states with respect to reimbursement. I didn't realize they were 6th. I know that there were some decreases in reimbursement for Medicaid earlier this year. I don't know where that might have placed us in relative position to the other states. Do you happen to know off the top of your head where we might have moved?
I don't. Unfortunately, again, this is kind of the national data that everyone looks to, and it's from 2016. So I think, would be great if we had something more current, but I don't have information on how AB3 changes this. And, there are a handful of other states that are going through similar situations at that point. So I feel like, a lot of this is in flux, and I don't know the periodicity on which Kaiser updates the study, but certainly interested in if there is a more current version that comes out soon, what those changes look like. But I would say just based on conversations we've had with our national association, there are a handful of other states that have also had to make changes to reimbursement rates or are in the process of trying to do so. So I think it probably shifts things for Nevada and other states as well.
And as we gear up for another legislative session to start in February, do you anticipate there being additional cuts in those reimbursement rates? Or do you think that there'll be data presented somehow that might keep it where they are, or perhaps even increased in some areas?
Well, I will say really grateful that the governor has been incredibly transparent about this process and put out a press release earlier in the month, stating that state agencies have been asked to look for an additional 12% reductions in budgets for the next biennium. So we submitted our agency request before that directive came out, and that is public information, and still working through, some of the changes that will get us to how we find 12% to reduce from what was previously submitted as part of our agency request. So don't have a specific answer to that question other than that we, like all state agencies, have been asked to find an additional 12% in reductions. And also that, we've been working through the process with CMS on the AB3 reductions, and it's a time intensive and quite a detailed process to go through getting approval to reimburse your reductions, to the extent that we did during AB3. So I guess we're still working on it.
Okay. All right. And one last question, to kind of piggyback on what Commissioner Khan had asked. I don't know if this is true or not. Maybe you can shed some light, or some of the other physicians or hospital representatives. If a provider chooses to not participate in Medicaid, in the Medicaid plan, are they thereby choosing to not participate in Medicare? Meaning, do they go hand in hand? In order to participate in Medicare, do you have to participate in Medicaid? And if you choose not to participate in Medicaid, are you therefore banned essentially from participating in Medicare? I don't know if that's true or not, but maybe you do.
I don't think that's the case. I can follow up just to make sure that's accurate. That's not my understanding, but I'll follow up with that particular question.
I see Commissioner Barron shaking his head no, so
I'm pretty sure you can be in Medicare without Medicaid, but
okay. All right. Thank you very much. I appreciate it.
Thank you. Appreciate it. Sarah.
Commissioner Bond.
Thank you. Ms. Bierman, that was really helpful. Thank you. And just special thanks for everything that Medicaid's done to try to get our many members sort of transitioned to what might work best for them. You guys have gone way above and beyond the call of duty, so I just wanted to call you out on that. I really appreciate it. Specifically, I think that when you talk about more budget cuts and when you talk about the impact on the doctors, I'm wondering what you guys think, what Division of Health and Human Services thinks and what Medicaid thinks is possible to consolidate your buying power. There are so many tax dollars that go into Medicaid. You're the largest purchaser in the state, probably. I mean, Medicare's federal, but as a state purchaser, Medicaid probably spends more healthcare dollars than anyone. And I know we tried to talk about ways to consolidate your purchasing power in the past, and I'm hoping that there's ways to do that around prescription drugs. I think that there has been talk about that in the past, and I think that would be beneficial to the members and the budget. So I'm just wondering if there's anything that's possible that we could support around that.
I think that's a great question, and Senator Kinsella and Dr. Slamowitz, who's the Senior Advisor for Pharmacy within the department, has certainly done a lot of work looking at that. So, you know, I think first the transparency measures and better understanding the data around that, and then seeing where that can take us through multi-state purchasing pools. I know a number of things have been discussed. So all things that we're interested in looking into and figuring out where opportunities live there. Also, I think, you know, the overall point that Heather made too around affordability and costs generally and the prices, I think we're interested in that as a payer with other payers and better understanding where opportunities lie to, you know, maybe make sure that we're on a sustainable path. So I think in terms of pooling purchasing power and also, you know, I think the committee talked about the Peterson-Milbank project around setting sustainable growth targets. All of those are initiatives that we're really interested in, and, you know, do understand that they're competing priorities for limited state tax dollars, and want to make sure that we're being good and efficient purchasers of healthcare services for the many Nevadans that rely on Medicaid for their health insurance coverage.
Yeah, I know. That Peterson project that specifically come to this PPC is a really good example of what we could do to help. I appreciate that that's been pulled forward for us. Yeah, there's a specific opportunity there. Appreciate that.
Thank you, Sarah.
Commissioner Van Helling.
Hi, good morning. Thank you, Director Bierman, for the presentation. And then also thank you to your organization for all the expertise and technical questions that you answer for us as providers. I do want to just piggyback off what Commissioner Khan's comments regarding other collaboration that we can work together. Your organization is very good on working through some of the barriers or questions that are out there. And I think there are other things that perhaps doesn't directly come down to reimbursement rates that we can work on that takes more around efficiency and throughput. So I would like to explore that a little bit more. UMC is also a presumptive eligibility organization, and we appreciate the entrusting our organization, but it is very high standards and accuracy rates. So we continue to work on our team's training, but also being able to help hold people's hands through the process. But my question, Director Bierman, is what's the strategy or the philosophy on enrollment with a new member, but then also enrolling them into a managed care plan within the providers that were explained earlier today? Is that, I know that we've been trying to shorten that window to get folks into a managed care plan, mainly around getting a primary care physician and getting things established versus the traditional Medicaid. But is there any more discussions around that, and what's the current strategy?
I think the process has, over the last couple of years, become more streamlined in the amount of time between the eligibility file coming over to Medicaid, and then a managed care assignment has been shortened quite considerably. I can follow up with specific information to you, but my understanding is that there's not a lot of lag time between eligibility determination and managed care enrollment, but certainly open to strategies and ideas. And if you're experiencing something different on the ground, I'm happy to work through any of those challenges with you. But I think the file comes from Weston. Again, I'm not always the best with all the technical details. It comes over to Medicaid and then electronically, managed care program or plan is assigned, and certainly there's consumer choice and an opportunity to select your own plan. I can get additional information, but I think the lag time in terms of the electronic data transfer has been considerably shortened on our end, and we'll follow up with additional information.
Yeah, and really no follow-up needed. And it wasn't a criticism at all. I think when you're looking at the value of the healthcare dollar and managing our resources, and then hearing that we're going to have more enrollees attempting to apply for Medicaid or some type of assistance within the state, I think just the efficiencies around that. And again, back to Commissioner Collins, I would like to explore. I just want to compliment you. I mean, I think one of the advantages of Medicaid, at least from a business and a provider standpoint, is the time for reimbursement and the pay. I mean, it's one of the fastest. It's Medicaid and Medicare on a clean claim definitely helps out providers' cash flow and be able to continue providing care. So again, I think there's a lot of good things that we could continue to look at, but also improve efficiencies on both sides. And we started some of those earlier conversations months ago about credentialing and expediting, but I think there definitely needs to be some collaboration, further collaboration on workforce and process to be able to remove some of the barriers in your own organization as you're tasked with doing more with less, as all of us are on this call. So again, compliments to you and your team.
Great, and we're certainly happy to work with you and other providers and members of this commission on identifying additional ways to find efficiencies in the program, because I know that we're all interested in that and ensuring that we're being really responsible stewards of taxpayer dollars. So happy to work with the committee.
And we've got some on our own side too. Is there's ways to do things better. We could definitely collaborate, especially in this technology that we all have.
Thank you. Sarah, to you.
We've got Dr. Slonim, Commissioner Slonim.
And thank you, Ms. Bierman, for your presentation. Much appreciated. I wonder if we can get a copy of your presentation, please. That would be great.
Sure.
In addition, a couple of things that you went over, which I think are important for us to emphasize. First, it seems like the data that we have that's published is 2016, right? That practically half a decade ago. And because of the time lag between getting the data and publishing it. Second, it seems that the Medicaid fee schedule for physicians is lower than, right? The Medicaid fee schedule is about 95% of the Medicare fee schedule. And so relatively proportion, when you look at that slide that you presented from that published manuscript, we're already starting at a negative because Medicaid doesn't pay as much as the Medicare fee schedule. And so the fact that we're actually much more, relatively speaking, we're not keeping pace with what the changes that are going on in the Medicare fee schedule. I think it's important, and Commissioner Flood brought this up, and I think it's really important for us to make sure that we emphasize it. We know that there are access challenges in the state. While we may have a number of people insured by Medicaid, if I put myself in the patient's lens, I know how difficult it is to achieve access, especially in the rural environment, especially in specialty care, and even sometimes in primary care, which is accentuated, as you mentioned, by our workforce challenges here. At some point, with additional potential cuts coming down line and other things, people can make a choice about whether they will provide care under the Medicaid program or not. And I think I worry about that a lot because it will certainly worsen the access problems presented by our patients. Do you have any, it didn't seem as though you had any information on hospital rates.
So the national study was Medicaid to Medicare for Physician Index. I did ask our supplemental payments unit within our finance division just for our own, so I don't have the comparative information, but the public inpatient Nevada Medicaid reimbursement rate is 100% of Medicare, and the private inpatient is currently 82% of Medicare. Certainly their hospital payment is inpatient per diem within a variety of supplemental payment programs, but that's the information that I have as to our most current Nevada Medicaid reimbursement rates as a comparison to Medicare rates.
Okay, and can you confirm that your analysis does not include the impact of the Medicaid MCOs managing payment? So it's not uncommon for payment denials to occur, specifically where people access the emergency department, which may be their only option because they can't get access to primary care, yet those denials that come in because it's non-emergent in nature. Can you share with us a little bit about how that was analyzed?
Yeah, I think you're right. I think all of the data that I have and presented today is based on fee-for-service data. I will go back with our finance team and confirm that that is also the case for the Medicare hospital data that I just presented. But yeah, it does require a more sophisticated actuarial analysis when you factor in the complexities related to the managed care organizations.
And I guess that's actually my next point, which is I'm wondering if I've heard it a few times. And again, appreciate the analysis you've done so far. Wonder if the commission could have those further actuarial analyses actually performed and brought back, because I think it would be worthwhile, rather than putting them on a shelf somewhere, that we actually understand what Medicaid reimbursement rates look like. For example, I think it would be helpful, while there may not be national data, and I don't remember who mentioned this before, but healthcare is local. I'd be happy with an analysis that looked at Oregon, Arizona, Utah, California, and Idaho as comparators for Nevada, given that we're kind of locked in, and see how they're reimbursing and what that looks like relatively to benchmark. I also am a little bit concerned, given that pivot point of vulnerable access issues and further rate reductions. I've only heard of Colorado having a 2 to 3% reduction in Medicaid, nothing nearly as significant as the 6% here, with a potential other 12% that I heard from you. So we're really looking at, I would say, strenuous pressure on access if some of these things continue to evolve. And I'd just like to know where we are for the benefit of our patients. Thank you.
Yeah, just one quick clarification. The 12% reduction that I mentioned wasn't an additional 12% reduction in Medicaid reimbursement rates. It was the 12% reduction that the governor requested of state agencies in their budget. So I just wanted to clarify that particular point. Also, AB 116 did look at funding those more sophisticated actuarial analyses, to get to your point. Unfortunately, that bill didn't pass, and it did come with a fiscal note. I believe it was somewhere around $150,000, and that would be, I think, 50% administrative match would be available. So I think that there was an interest in that last legislative session. Unfortunately, it didn't pass, and kind of budgetary constraints right now. I think would need some additional administrative funding. It's not something that our internal team can do without relying on our contracted actuaries, but happy to continue to have the conversations, but did just want to flag that that was a piece of AB 116 from 2019.
Thank you. I think the one final point I would make, if I could, Commissioner Khan, is we've talked a lot here about the finances of Medicaid, certainly. The title of our commission is the Patient Protection Commission. It would be nice to understand some of the clinical elements of what these low rates mean in terms of actual patient impact. Patients who cannot get access because clinically there are just not enough clinical people to care for them, and what that means in terms of deferring needed services like primary care, like access for care for a tumor that you might be concerned about. like only having the emergency department open where there are adverse impacts on care. If we're doing our job as commissioners on the Patient Protection Commission, it seems like the conversation needs to go beyond finances to actually how we can protect patients. Thank you.
Thank you. Sarah?
Sure. Actually, I'm sorry. I think I cut off Commissioner Bond a little too soon. Commissioner Bond, did you have a follow-up?
Thank you. I think I cut myself off. I appreciate the second chance. I wanted to clarify something Dr. Slonim just said, which I think that you said that the data that Suzanne presented was almost a decade old, and I thought you said it was 2016.
No, I said half a decade old.
Oh, half a decade old.
Half
Right.
a decade old.
So I think my major point is it would be wonderful to have whatever data you do have that's national presented to the legislature in whatever format you can, because they don't have, often during the session, they don't have comparisons of what's going on in other states. And so I think that would be one request I'd like to make. And I think this commission, even though we are talking about rates and not patients right now, does have a need to create as much transparency as possible to understand what's going on. And this today is one more example of the need for transparency, the importance of seeing data. So I don't know, Sarah, if we can refer back to you for any other ways to get state comparisons. I don't know if it's something that the Peterson Group is able to help us with, but I think several people here today asked for, more information about what's going on and what's current. And while it is 5 years old, that data, it's still after President Trump became president, and there were a lot of changes to funding streams when that happened. So I think it impacted all states. So even though our state's been dramatically impacted by funding issues, every other state has as well. So maybe the trends are the same, even though it's later, but more data would help on that. I appreciate it.
In addition to that, I think you're totally right. If we could get more nuanced data, so like on mental health, it'd be interesting to see different provider types and see like where we are nationally in reimbursement. So mental health, dentists, I think, are an issue. And I know Commissioner Bond, you said you've done a lot of work around that. But I have to say, I hear stories in the rurals. I mean, they go to the ERs and ER doctors are pulling people's teeth out. It's like, are we in a third world country? So anyway, I think that'd be great to see specific provider types.
So thank you. So we need to complete our list of commissioners who haven't spoken yet.
Sure. And I'll make a note of the data requests and seeing what we can do. And I know the Peterson program, I think that if Nevada was accepted, would get some technical assistance from a healthcare consulting firm that I believe has worked with Rhode Island, Delaware, Oregon, and Connecticut, I believe, are the states that they've worked with. So that would be a great opportunity. And nonetheless, I will follow up with the data requests and see what I can do. The next commissioner we have is Commissioner Packham. And actually, maybe Dr. Packham might have some recommendations too.
Thanks for the presentation. I don't really have any additional questions, but when you send your PowerPoints, could you possibly send us any updates you have on caseload growth? I think we're kind of interested in tracking that through the pandemic and the recession. So thank you.
Okay, we haven't heard from Commissioner Barron. Is he at the bottom of the list?
Yeah, it's okay. Commissioner Barron is next, but commissioners, I know that I sent you Administrator Bierman's presentation early this morning. You should have received it. If not, we'll make sure to follow up. And for everybody who's watching, I know that Leslie will be posting it later to our website as well, so everyone can view the slides and get those on our website later today. And then,
all right,
Dr. Barron.
Hi. Suzanne, thank you so much for the presentation. Couple of points. As Dr. Slonim mentioned, the data from the Kaiser Foundation is going on 5 years old. It also, it's interesting to me because I actually have some data that I gave in a presentation to the Las Vegas Medical District a few years ago about how Nevada ranks state by state with regard to percentage of Medicare reimbursement. And when you look at it as a ratio of provider availability, we rank right up there with Wyoming and Alaska and South Dakota and some of those places with regard to the paucity of providers in many different areas, and yet our rate of Medicaid reimbursement is below that of Medicare, whereas Alaska is about 1.16 or 1.2 times Medicare. Of course, they're an oil-rich state, and we're not. But they have similar provider ratios that we have. So in talking about access to care, it's important to make sure that we're, that as maybe unpalatable as it is for this commission, it's important to look at reimbursement rates for hospitals and providers of various specialties, because that does incentivize or disincentivize people from getting access. With regard to the AB 108 passage, it's important for the commission to realize that mandated an every 4-year look at rates of reimbursement. It did not mandate any adjustments in those rates. Okay, it certainly stopped short of that. And if you look back historically at Medicaid reimbursement rates in the state of Nevada, it's been more than a decade, I can tell you firsthand, that there has been any adjustments in reimbursement, and those have been down. They have not been up. So it's ironic that we have a reverse in ratio in terms of the percentage of our citizenry that is covered by a Medicaid plan, whether it's MCO or fee-for-service Medicaid. And at the same time, we have had a steady downward trend. If you think cost of living adjustment is important in most businesses, it is. We've not achieved that in reimbursement either to institutions or to physicians, with the exception of a small 5% change in hospital reimbursement for certain services on the last legislative session, most of which got peeled away with AB3 in the special session. So I think it's important to kind of keep that in perspective. I too am concerned, as is Dr. Slonim, with the concern about access to care as we increase and pad our Medicaid enrollment numbers, and at the same time we aren't building more providers for those services. And so I think workforce is a real important issue here. In states in which the workforce is more robust than ours, the access to care for Medicaid patients isn't as much of a problem, irrespective of what their reimbursement rates are, because there's more competition for patients. Here, there's more competition to get into a provider than there is the providers competing for patients. And so it's kind of important, I think, to put those things in perspective. That said, I am a big believer in being a good steward of the limited funds that we have in our state. And I think that there's lots of ways with boots on the ground that we could improve our stewardship of those funds, limited as they are. And lastly, I was going to mention that, when those 6% cuts came down from the special legislative session, we also gave away, I think it is $3 of federal matching funds for each dollar that we sacrificed in those rates. And so, we're one of the only areas in which we give up 2 to 3 times the amount of money in federal matching funds compared to almost any other side, issue in the budget, in which if you do a 12% cut in all services, that you're giving away, $3 to every dollar that you cut, that the state passively was able to receive. And so it's important for us to understand those aspects of our budgetary process as well. So I appreciate the presentation, and that's all I had.
Thank you, Howard. Do you have any comments on that, Suzanne?
No, I think those are all valid points, and I don't have any follow-up other than to say you're exactly right about AB 108. It does require us to look at the rates and make recommendations, but doesn't require a change in reimbursement rates. And I think, again, that was part of AB 116 that didn't pass, was to figure out how much additional state general funding it would cost to address, some of these disparities between Medicaid and Medicare reimbursement rates. So I agree with all your points, and especially the point about Medicaid being jointly financed. And so when you cut the state dollars, certainly there's reductions in federal funding that would otherwise flow into the state.
So thank you, everybody. Appreciate all your comments. But to sum it all up, as I alluded to in the beginning, in my opinion, you mentioned about, we talked about the rates. We're talking about rates today. But that's the problem with the whole vicious cycle. As the rates go down, patient access goes down because more and more providers cannot sustain with the cuts in the rates every time around. So it does impact patients in a direct manner. Number two, and I mentioned this many meetings ago, and I'll just repeat myself, we have a huge challenge, and this needs to be addressed with the department, your department somehow, if there is a possibility that when the patients are coming to a hospital, they are sitting there for days, literally, and I see this every day, where they cannot get a bed to an extended care facility because they do not want to take Medicaid, whether it's LTAC or a rehab or a nursing home. It's not good for the patient. It impacts patient care. They sit exposed to nosocomial infections in the hospital the longer they stay there when they don't belong. They also take away a bed from an acute care patient coming through the emergency room because these patients, 10%, 5%, are using an acute care bed when they really don't belong there. So it backs up the access, especially in this COVID days. So not for today, maybe offline, if you could be kind enough to get some follow-up on this challenge on a day-to-day basis, whether the department can address that in some way or short. I don't have an answer. I know there's budgeting restraints, etc. But offline, if you could follow up on that. So with that having been said, I think we have kind of had the whole thing addressed pretty comprehensively with a lot of good suggestions, a lot of offline work for you to pass on to all the commissioners. So please kindly make sure they all have access to their ASAP and that they are able to directly have additional questions asked of you based on your responses to them. If you could kindly make yourself available to their further questions they might have after you give them the information they requested. So I appreciate everybody's input. So that brings us to our next item, number 8, discussion of Commission's top priorities for future recommendations. So just to recap, we have taken everybody's input, put a number to the sequence of next priorities. So we have item A and B, review of healthcare workforce issues in Nevada and consider recommendations to improve access and delivery of healthcare. And item number B is review of effect of any changes to Medicaid, including the cost and availability of healthcare and health insurance in the state. I think the item number B was pretty extensively discussed in this last presentation. And correct me if some of you don't agree with that, but at least maybe we start with item number A. Sarah, do you have any input to give on that before we take the commissioner's questions?
No, but I would like to remind the commission that Dr. Slonim sent out some of his recommendations around this topic and some information. I think I sent that before, so perhaps Dr. Slonim may want to address the commission first, but I would defer to both your judgment and Commissioner Sloanum's.
That's fine with me.
Thank you, sir. And Commissioner Khan, I appreciate that. I believe that, as you've heard me say on multiple occasions, workforce issues in Nevada are in some ways the rate limiting step to achieving high quality healthcare for the citizens of Nevada, and no greater issue has come before the Patient Protection Commission. We're fortunate to have expertise among the commission, including Dr. Packham, who can, and members of the boards who can help us really address some of these issues. I'd like to be able to continue to advocate that this should be one of the top priorities, especially in the context of COVID, which we know is really hurting people on a number of levels, including access. And so maybe a presentation at the next commission meeting that puts this front and center so we actually can understand what we're talking about, and not to give Commissioner Packham the work, but he's an expert in this. And we have an expert among us. We might as well hear from him and use his talent to the benefit of our citizens.
So point well taken, Dr. Slonim. I have no problem with that, taking up the next meeting with the information presented by Dr. Packham, if he's okay with it, to pursue this, since this was one of the top items polled by the commissioners on that. Without getting into a very crisscross discussion, any specific opinions on this? And I think in fairness to Dr. Barron, who was at the bottom of the list last time, maybe we can go to him first this time. Dr. Barron?
Yeah, no, my only comment is I think that would be great. I've heard Dr. Packham's presentations previously in a few different venues, and they're always very thorough and complete and give us a huge insight into what our workforce issues are. So I would be very much in favor of that being an agenda item next time.
So unless somebody has any objection, Dr. Packham, would you be all right for our next meeting to make your robust presentation, and we can have a robust discussion on it based on your premise of all this work that you have done?
I'm happy to do that. Your timing is excellent. I've already put together a presentation for the incoming new legislators, and so I'm ready to rock and roll.
That's excellent. So I think we'll take it up at our next meeting, and we can all rock and roll together with you next time around. Thank you very much, Dr. Packham. Really appreciate your hard work in this regard. And I'm sure it'll be very, very valuable. Workforce, as we have all discussed previously, is a crucial issue throughout the state. And we'll have a robust discussion at the next meeting. Sarah, could you please allocate reasonable time when we are preparing our agenda for the next meeting?
Of course.
So that we don't compromise this discussion by cutting corners with our time restraints next time.
And Dr. Packham, if you already have a presentation that's ready, if you want to send it to me, I will get it out to the commission as soon as possible so that they can look it over and have prepared questions for you that might help with efficiency at our meeting and timing.
Will do.
So thank you very much for that. As I said, item number B, we have had extensive presentation, cross-questioning on the to Medicaid and cost availability, healthcare and health insurance in the state. Unless we didn't cover something, any commissioner has a compelling additional comment on this issue, in addition to what we have already discussed earlier with Suzanne's presentation and everybody's input and questions.
Sure, do you want me to do a quick roll call?
Yeah.
Okay.
Or if there are just a couple of commissioners who want to do this, we could do that.
Sure, let's Commissioner Bohannon.
Thank you. I think just listening to everybody's reactions to the Medicaid conversation made me just think about this in terms of outcomes and really seeing Medicaid patients through the lens of the social determinants of health and how that all impacts some of the outcomes that we see. Some of these, attaching dollars to it. I think that we're dealing with a population who has a higher burden of chronic disease and other types of, substance abuse, mental health distress, and then, obviously adding the pandemic into it. And I'm always sort of thinking through that lens of there's so many other things that these people are dealing with. Food insecurity, energy insecurity, housing insecurity, and all of those things impact their health and those outcomes. And I think that we have to get out of how much did this cost, what are the providers, that sort of thing, and thinking about it sort of holistically. And one thing that we might consider doing in this report that we are supposed to develop is maybe just really dedicating an entire kind of chapter to looking at our Medicaid population, doing these deep dives, really getting that information that everybody's requesting, and so that we can identify how we can better serve this population, because these are chronic issues that aren't going to go away if, say, reimbursement rates go up tomorrow. There's so many things that are impacting this particular population. And so I'm just really thinking about how can we holistically address these populations, because we saw a lot of kids move from CHIP to Medicaid. And that is an indicator that we are seeing more kids fall into poverty. And I don't know if anybody looked at the recent kids count report, but we are failing our kids in Nevada. And that leads to a lifetime of healthcare costs. And so that's really all I want to say. So thank you so much for giving me that opportunity.
Thank you. So what I would suggest, Sarah, if you can please, if Suzanne is left, pass it on to her. So when she summarizes everybody's input and opinions and views on the offline, to summarize those and come back with the responses to them for our consumption next time around, including what just Commissioner Bohan just mentioned for a holistic response from her. How does she propose to approach that, or at least update us on that? Does that make sense?
Yes, it does. And
Everybody?
I will follow up with Administrator Bierman as well as Director Korbulik and see if we can have a offline meeting amongst the commissioners, or at least get some materials and recommendations kind of shared back and forth.
So if it is okay with everybody, should we then defer some of our additional questions besides the one requested offline already for the department to come back to us on this? I think I saw one hand up. Any other additional comments while we are pending all the responses we have asked for?
I'm sorry, I lost track of what you're saying, Chair Khan. Are you asking for responses from us regarding today's presentation, or about the larger agenda of the direction that we need to go? I'm sorry.
So I think if we missed, what I'm saying is if there are some elements that we missed in the earlier discussion and presentation by Suzanne, and a lot of questions we had, she's going to come back with us after taking the offline access to her, as I requested that she make herself available. So we'll get responses to all of those from her, hopefully at our next meeting, and we can have a further discussion on it at that time. So as of for today, is there any additional specific thing that we may not have already addressed or asked her to come back to us with?
I have one. Can I?
Yes, please.
I have one thing I'd like to add. I appreciate it. I think that once the legislative session starts, DHHS and Medicaid are put in this position of being able to provide information, but not really advocate. And I think it would be great if we could get them to provide a list of the things that they think would be helpful steps to achieve our goals of patient protection. And unfortunately, it is an affordability issue. If we had unlimited resources, healthcare resources are finite. If they were not finite, we would be doing better on all these fronts. But what could we get from DHHS and the Medicaid program as their list of action items that they'd most find value in, when they very rarely get an opportunity to provide that? They're mostly just responding to requests. I think it'd be great to open the door a little bit for them.
All right, appreciate that. Thank you. Sarah, do you see any other compelling, I mean, urge for somebody to put in any information for this next discussion from DHHS?
I don't see any. I don't know if any commissioner wants to just raise your hand so we can. And so you're just asking if somebody's raised their hand in lieu of me continuing down a roll call.
Right. Otherwise, because if we can go down the line, but I thought we have already had a pretty exhaustive discussion earlier. So as I said,
okay. Well, I was going to say some commissioners may have just been waiting until their kind of roll call. So, I see Commissioner Flood. I don't have the I didn't have the gallery view. So Commissioner Flood, I think you raised your hand. Yeah.
Yeah, I just wanted to say, I think Commissioner Bohannon was really right on about that determinants of health. And then also it'd be interesting to get information on the innovations that Medicaid are looking at. You know, one of the commissioners applauded Medicaid and their staff right now. And I think they've got a pretty incredible crew working on this stuff. So it'd be great to know the innovations that we could support. And then also, you know, this just was making me think cost benefit, bang for buck. You know, a lot of research has shown in society that investment in the youth is important. And that's one thing I've noticed in Nevada is like you have your youth advocates, but they're pretty siloed. And so just making sure that we're really taking into account like whatever we're trying to do for care coordination for youth.
Thank you. All right. So I have Dr. Slonin.
Thank you, Chair Khan. I would agree with that. I think that there's, right, I mean, when you think about the most vulnerable in our communities, those are the ones who are insured in some ways by Medicaid, behavioral health, child, maternal health, seniors, and the aging. And I agree with Commissioner Bond, asking for DHHS's opinions about what we should be focusing on would be helpful. I also think we could benefit. We are pretty much across the board on any number of metrics suffering from impaired health status. If you take any one of those priority populations, our performance as a state is disgraceful. And so at the same time, if we look at the macro picture, we've got outcomes that are poor, access challenges, workforce challenges, and reimbursement that is such struggling and likely to get worse. Wow, sounds like a setup for disaster. I don't know how we go. I think we're 51st in the nation for behavioral health. We can't go lower, but what other ones will deteriorate as a result of this constellation of symptoms, I'll call it?
Thank you. What I would suggest, those of you, I've seen a couple of hands. Otherwise, please pass on all these requests to Sarah, and she can pass it on to DHHS to prepare for the next time around. I think, Sean, I saw you had a comment.
Yeah, real quick. As a representative on this commission of one of the managed care organizations that partners with the state and has for 20 plus years with respect to Medicaid, we have our medical management, case management team that interacts with Medicaid enrollees on a regular basis. If any member of the commission would find it useful, you don't have to say it now, but maybe we can get with Sarah after the fact. I'd be happy to arrange for somebody from our Medicaid medical management team to come and talk to the commission, just share with them some of the obstacles they encounter on a regular daily basis with respect to members. I know we're hearing from high level DHHS what they see, but I think sometimes it's worthwhile to hear information from those folks that interact with people on a regular daily basis. So if members of the commission find that to be beneficial, I'd be happy to arrange that with Sarah to have them come and talk to us for 15 minutes at a future meeting.
So that's helpful. Sarah, could you make a note, please?
Yes, absolutely. And Chair Khan, if I can, I would be remiss if I didn't mention the Advisory Committee on Medicaid Innovation. I want to remind this commission that back in July 24th, they submitted a letter to this commission with several recommendations, and I would encourage the commission to kind of revisit that. For time's sakes, I won't go over their points, but I can recirculate that to the commission as well, and then would also suggest for this body to maybe consider having me reach out to Chair Barclay and seeing if she would like to also collaborate or come in front of this commission and open up a discussion.
So that would be very, very helpful, but also, like you already said, please pass on that again to all the commissioners to refresh our memories, and then we'll take it from there. So I would really like to move on to our next item if there are no compelling issues, or you can pass it on offline to Sarah to pass it on to DHHS for inclusion in the debate for our next agenda for the next meeting, hopefully. So having said that, item number 9, Sarah, this is your area, discussion of report to the governor and the director of the Legislative Council Bureau.
Yes, so thank you so much, Chair. This is another item that I see as kind of a standing item until our report is due. I know at our last meeting, we kind of opened up the discussion, and I will remind the commission that we have a statutory obligation to submit our next report January 1. By default, this report will be from me. That'll just kind of outline the commission's activities and the recommendations that you guys have formally adopted so far, that being your bill draft requests. And so I just wanted to have this on here as an opportunity to continue that dialogue, answer any questions that you might have. I know Commissioner Bohannon, I think you requested last meeting for kind of an outline or frame because you think it would be a little bit easier to kind of see that. I owe that to you still, and I will get that to you and to the rest of the commission as soon as I can. I think that that might help just kind of see where my mind is on the framing of it. But again, I welcome any recommendations or suggestions you have to adding to it or changing the format. There isn't anything that's kind of set in stone. I will just kind of tell you where I'm at with it now. And I don't know if it's realistic that we can have a draft ready by mid-December. I think that was the kind of the timing that I was looking at, what I mentioned at the last meeting. But depending on when you all would like to meet again and you know, what your thoughts are on adding in additional recommendations, I think that maybe I'd have to revisit that timing. That timing might not be realistic, but I will do my best.
Okay, thank you very much. So keep us posted on your report, basically on that. And then we will follow, people can chime in when hopefully you have your draft or working draft. So we'll take it from there. So this is a work in progress. We don't need to do much of it right now in our meeting today. The other item on the agenda is item number 10. This is again strictly an update, not for discussion, to let us know how the bill drafts are progressing, because we have already had all our discussions on those subjects. So any new updates, Sarah, of new developments, if you can please stay focused on that. Any new developments or any updates, we need to know how it's progressing.
Sure. Thank you so much, Chair Khan. Again, this is a status update. I feel like it's old news now, but really at our last meeting, the update was that we had not received any a bill language from the Legislative Counsel Bureau, but since our last meeting, we indeed did receive the draft and it has been pre-filed. It is now made available for public review, both of the BDRs. I believe our telehealth BDR, which was BDR 416, is now Senate Bill 5. And our bill draft request on transparency is now Senate Bill 40. Again, that's available for the public to review. And what we have done is we have placed on our website a more information about those measures, and also provided an opportunity for any member of the public or anyone who would like to engage to submit any commentary, that they have a form that they can submit and share their thoughts about both of those measures with the commission.
So I believe this is on to the legislature now,
Right.
where it belongs, rightly so, and any further discussion from public or otherwise would go up into the legislative session,
right,
where people will have the opportunity to comment on those drafts at the legislature come January, February, or whenever it comes up for discussion and debate in the legislature. So I just wanted everybody to know how they have been progressing, and now it's for public record and consumption and beyond us, and then moving on to the legislative session.
Yes, the Nevada legislature, for the public that's watching and is not aware, is set to begin on February 1st, 2021.
Right, and this may not come up for discussions immediately, but at some point it'll come up based on how the legislative process works, and they bring it up on the agenda item. Having said that, we have item number 11. These are standing agenda items. Sorry, did I hear somebody?
Dr. Khan, John Packham. I had a real quick question regarding one of the bill drafts. I don't know if you or Sarah has any insight into it on the all-payer database. It looks like at the top of that bill draft that this would require a 2/3 vote by the legislature. And I just wondered if anybody knew what triggered that. I've read through the bill twice and just don't know if somebody could maybe explain why that's going to require 2/3 vote.
Sure, I can take that question. Let me just pull it up really quick so I can see. So if you see at the very top, it says 2/3 votes required. That's section, and it references section 13 and 17. And that is for the administrative fees. And so anytime that there's a fee associated with the bill, it requires a 2/3 vote. And because the state is either receiving revenue or assessing a fee.
So basically, it's about the financial impact, if any, then that triggers that at that point.
Correct.
So, but that will be up to the legislature to make their determination why and how, depending on how they proceed during the debate in the legislative session. So, I think, go ahead, anything? Did I hear somebody trying to say something?
This is Commissioner Shaner. I have a question, but I don't want to cut off Commissioner Packham.
I think I've got it. Thanks.
Okay, thank you. Go ahead, Sean.
I appreciate it. I just wanted to share that I had submitted some comments with respect to the bill drafts, none of which were incorporated in the final document that was submitted. So I do think the bill drafts still need some additional work, and obviously that'll be taken up when we go into session, but I just wanted to share it with the rest of the commission and the public that I submitted several comments, particularly on the all-payer claims database bill. And I look forward to discussing those when the session takes place.
All right, thank you, Sean. Appreciate that from you. We have Commissioner Flo Khan.
I just want to reiterate what Commissioner Schoner said, that we too submitted comments or requests for some additional revisions to the draft. Those were not accepted either. And so we just want to let that be on the record that we will be obviously talking about that when it comes to the session as well.
All right, appreciate that. Thank you.
And Chair Khan, just for clarification, I just want to make sure that the public is aware too that yes, indeed, and I appreciate Commissioner Shaner and Commissioner Flo Khan indicating that they had shared some comments and feedback, and we didn't accept as a body any requests for modifications from the original draft. It was a decision that was made to not make any modifications that weren't complete obvious errors and omissions. And I think some of the suggestions were not clear errors and omissions. And I worked with our attorney on that. And so what we did is we just made a decision not to make any modifications. So it wasn't a decision that some got in and some didn't get in. I just want everybody to know that no modifications were made to either measure.
Yeah, that's true. Thank you. I think we need to move on to item 11, standing agenda items for possible action recommendations for commission activities and or report to the governor and the director of the Legislative Council Bureau. What action are we expecting here, Sarah?
I think this is just a standing agenda item again to allow the commission to make formal recommendations to be included in the report and for you guys to have consideration. So this is just giving you an opportunity to submit a formal action on a recommendation for commission activities.
So that you already addressed that on your earlier agenda item that you're going to.
Yeah, the earlier agenda item was a discussion only. So this is just kind of formality, allowing you guys to take action if you wanted to consider action on making any formal recommendations. So it's more about.
So, but we are not there. I thought we just talked about it. If there are any formal recommendations for the report, the governor, etc. Will be submitted to you, and when you're preparing your draft, you will try to incorporate that.
Right. And it's fine. This is, again, just an opportunity if you wanted to take a formal action to make a recommendation for one of the future meetings that you guys could discuss it, and it would just be on the agenda. Otherwise, I will just continue to work with you, Chair Khan, offline as we craft our next agenda and our next activities.
Yeah, I see Babette Bond has her hand raised.
Thanks, Chair Khan. I'm trying to get a clarification here. I think we had that conversation either in the last meeting or in maybe the meeting of, maybe another meeting. We've talked about Peterson Group and we've talked about having the AG's office come present, and I just wanted to, I thought those were moving forward, but they're not on any agenda item now. So I just maybe this is the agenda item to clarify that. Are we going to hear more from them? Can we hear more from them?
Thanks, Commissioner Bond. So the Peterson Milbank, I know the last meeting, the commission voted to support Director Whitley and collaborate with him on that effort. And so since then, I have followed up with Director Whitley and Peterson Milbank. It's in the queue and next steps for Nevada to try to get the application. So the next process is that they would have to send our governor a letter of intent, or and then we would have to formally apply. But that invitation has to come from Peterson Milbank. And so Director Whitley and myself reached out to Peterson Milbank to let them know that Nevada is prepared and would like to be considered. And so it is in process. It just isn't an update yet because so it wasn't on the agenda. As far as the AG's office, I have not yet been able to confirm them on a next meeting agenda, but they are also in queue for me to reach out to. But there's nothing formal because it just hasn't been.
Okay.
So I
So we haven't lost anything. Thank you.
Right.
So I think that will take us into the next item, an item B, which will address some of the questions being raised for possible presentations for future meetings. I think we talked about a little bit during our discussion what we would like to have presentations for future meetings, plural, not just the next meeting only, because we need to keep mindful of our timings, how many presentations we can include in each meeting. So any thoughts? I think if we need to go in sequence to all the commissioners, if they have any thoughts for presentation for future meetings, which will also take us into discussions of potential agenda items. The future meetings, presentation, and agenda items will go hand in hand. So any specific thoughts based on what we have already discussed earlier in regarding to future presentations, or hopefully some in the next meeting?
Commissioner Slonim, I think, wants to say something.
Sure.
Thank you, Chair Khan. I want to just make sure I'm not confused. So in agenda item number 8, we have the commission's top priorities, which I guess we'll fast forward into presentations. But I just heard some additional presentations coming our way. I'm having difficulty trying to figure out, are those also top priorities, or are they different than top priorities? I heard both the Peterson report and the agenda. I'm not sure how it all works its way out. I'm having difficulty figuring out.
So before I recognize, sorry, Bond, for a second to answer that, we're trying to focus on the priorities we have talked about for future items. And if some of these get incorporated in that, we will look at that, which become incorporated into some of our priorities we have already discussed. Bobette, you had a point?
I just wanted to clarify what you just said, Dr. Khan. I think that we had 4 priorities. My understanding is where we left off, we have 4 priorities that got the number of votes. And these 2 presentations that I mentioned today had to do with those. They're cost related. So I'm not trying to expand the universe beyond our 4 priorities, which I think we all agreed to.
Good.
Yeah, so this will be a part of one of those priorities, actually.
Thank you. I just wasn't clear on how that fit in. So thank you for that clarification. So there are actually 4, if I'm interpreting correctly, there are actually 4 priorities the commission has, and we're following that rubric as we continue to move our work forward.
Yes, absolutely.
Thank you.
Thank you.
And Dr. Slum, just for clarification, I think what we did is we didn't want to have too much on one agenda to allow it. So we just chose the 2 most relevant topics because of the prior presentations.
I perfectly understand. I just wasn't sure of the process. Thank you.
Thank you. So and I thought item number C again is discussion of potential agenda items. So on that, what I was, other than what we've already talked about and discussed, if the commissioners have any thoughts on future potential agenda items relevant to our priorities that we have discussed, then which it'd be good if you share with Sarah to see if they can be incorporated in some, if they are relevant to our priorities, and then incorporate those in the future agenda items accordingly. Does that make sense to everybody? All right, Babette, you have a...
It makes sense, but I get confused about what needs formal action and what can go to Sarah, and then it just seems like it's informational until it gets to us, and I'm fine either way. But we have also raised the issue of what came out of the prescription drug workforce that Senator Kinsella led, not workforce, but prescription drug cost recommendations. And I'm not sure the best way to, I don't want to, expend more time than the commission has, but I do think that issue should come back to us in some way. So is it just review those or provide that information to us what those BDRs are? Or is there a way to have Senator Kinsella present it to us or somebody else? I'm just opening up the issue because I think it is very germane to the PPC's work.
So if, Babette, do you think that comes into relevance with our priority items we have discussed? And if so, in which one, if you could share with Sarah?
Okay.
If it's a part of one of those 4 items, then we can incorporate that.
Okay.
If you have to bring Senator Kinsella in, if it is a part of those priorities, like you mentioned. Does that make sense to everybody so far? All right, so the next one, we talked about possible discussion of future meeting dates. So just so that we all know, I think, Sarah, refresh my memory, there was the next date that was sent out, potentially.
Yeah, I think Leslie sent out, Leslie, I think I said the 15th, but I think you corrected me before. It's the 14th is what I think you surveyed the commission on, and I'm not sure where we were on that, and I'll let her speak to that.
So before we go to that, today is the 30th, so it's 2 weeks. So realistically speaking, and Sarah, you may be able to answer that, the items we've discussed for future presentations and et cetera, and our priorities, do we have enough time to have those people relevant to those presentations to get them in 2 weeks? Or you'll need more time? So I need that answer before we seal in this date of 14th, and if there is room to move it forward if all those logistics cannot be put in place.
Yeah, I really appreciate that, because I think it was a little bit challenging to get some presenters even in for this meeting with that 2-week time frame. And with the holidays coming up, I suspect that might actually be an issue too. I have yet to confirm the availability of any of the presenters outside of Dr. Packham, who has generously offered to present to the commission at our next meeting. So right now we only have one presenter, and I cannot speak to the other availability until I reach out, and so I will do that. But I do think that there could be some challenges for sure.
So thinking out further from that, if those challenges are obviously there, and then the holiday season around Christmas and New Year comes in very quickly, if some of those are not presentable by the 14th, I don't think we'll have an opportunity to have another meeting before the Christmas season kicks in or that week. So I hope we are all realistic about what may be available on the 14th based on what Sarah is alluding to, what time it takes for people to come prepared other than Dr. Packham's report, which is apparently ready. So as long as we are aware of that, so whatever can be done on the 14th, we should hold that meeting and take care of it, and not feel left out if a lot of things that we want in that meeting in terms of presentations cannot be put together in that short period of time. Does that make sense to everybody? Anybody has some thoughts on that? Yeah, I see one hand up, 2 hands up, Flo, and then Teresa. Commissioner Flo Khan, you're on mute, I think. Yeah.
Yeah, I'm sorry. My hand's not up. I'm good.
Oh, okay, all right. Sorry, I think Commissioner Bohannon, is your hand also not up?
It was up. I actually would welcome a meeting where we maybe just had one or two, or like one presentation. If we just did a really deep dive on workforce development, it was obviously our top priority. So I mean, I think it would be definitely worth our time to have more time for conversation and not feel expedited or that we're taking up other people's time. So I think it would be fine, even if we just had Dr. Packham present on workforce and kind of seeing what the needs are. Because I honestly don't know, if you went down every single thing, what our needs are per each kind of segment of the healthcare sector. So I think it'd be worthwhile.
So, okay, so that's fine. If I may suggest something. So other than Dr. Packham's presentation, other than the fact we discussed about DHHS people giving the information back to all the commissioners that they had requested offline ASAP. So if at all it's possible, those answers are fine. But if there are other areas that DHHS may want to come back and give the commission, not a report necessarily, but highlighting some of the key elements or essences of the offline information that was passed out, so that can be discussed. If that is possible, that could potentially be the next agenda items of DHHS. They don't have to prepare for us, but hopefully they are available to come back with their input from all the offline information that they would have passed on, so that all the commissioners' offline areas have been addressed and talked about in the open meeting. If that makes sense, so that could be the two pretty significant time-wise agenda items for the next meeting. Does that make sense to all the commissioners, or anybody has any different thoughts or ideas? Yes, Commissioner Bond.
Thank you, Chair Khan. I think that's a good agenda. I would like to just highlight something that we got from Dr. Slonim. I don't think the issue of GMEs is that well understood, and I don't know if it's going to be part of what Dr. Packham was going to present in the workforce thing. So if there's any way to make sure that gets, maybe we have time to add that to Dr. Packham's presentation, or maybe Dr. Slonim has a way to get some expertise around that, or Mason. I think both of those have hospital systems that are impacted by this. I just think that's a complicated issue and super valuable to the commission.
So thank you very much, Commissioner Bond. So I think that's a very good thought about the GME. We have some time. So between your questions, some of the people who are impacted by the GMEs, if we could focus on their input, and then after their input, then Commissioner Packham can let us know whether they could be incorporated or not. So a couple of people, the hospital side you have mentioned, especially UMC with Commissioner Van Holling. And I'm not sure whether Dr. Barron is involved with any GME, so maybe a comment from him on that for Commissioner Packham to see if that can be incorporated in a timely manner. So could we take that? I saw Dr. Barron's hand up, and if Commissioner Van Holling is online, and if Commissioner Slonim have any input, because either people impacted by GME for Dr. Packham to consider. Dr. Barron?
I actually have some new GME data to share, so your timing is good.
Okay, perfect. Dr. Barron, your suggestions, and then Dr. Slonim.
Yeah, I agree with Commissioner Bond that it's an important topic, and it's something that everybody on the commission needs to understand, including, the financing of GME, what the state is putting in, how those dollars are being spent, how those graduate medical education slots are being filled. I sent some data from a study that was done by some medical students actually about the percentage of GME slots in our state that are being filled by Nevada graduates, medical school graduates, versus coming from outside. And there was some argument made in that study that was published and presented at a meeting that maybe we should be incentivizing our medical schools to select graduates from our own medical schools first, trying to keep them in state as opposed to losing them in the GME slots that we have. So I sent some of that data to Sarah, and I think the last email I got was she was going to, quote unquote, take a deep dive into it. And so I hope that she held her breath when she did that. But that's something that I'd certainly be happy to share with the commission.
Appreciate your input, Commissioner Barron. Dr. Slonim, hospital impact, and if Mason Van Howling is still online, then he can comment. Though, Dr. Slonim, do you have any thoughts vis-a-vis GME?
Yeah, very important. And thank you, Commissioner Bond, for bringing it up. I think it's very important from the hospital perspective, obviously, and the ongoing workforce. I love the idea that we can include it, and I have nothing else to add at this point.
Thank you. Is Commissioner Van Howling online? I think he may have dropped off somewhere. So that makes sense. So Dr. Packham, any final thoughts on that?
I'm happy to include that.
That'll be great. That's perfect. So I think moving right along to our next. Sorry, somebody.
Can we just confirm though? While we have everybody's attention, it wasn't clear to me that everybody's available on the 14th. Can we just confirm that is a date that we can set? It just helps me with planning and reaching out to.
So let's do this if anybody who's not available on the 14th. I think the dates were sent out earlier, and I don't recall anybody saying no to it that I am aware of, at least. So I don't see anybody's hand up saying that they're not available. So that answers your question, Sarah.
Great. So we'll set it for the 14th then. Okay,
perfect.
great.
So we can go to the next item, public comment. Sarah, could you see if there's somebody in the north for public comment or south?
Sure. Again, anybody wishing to speak during public comment, this is your opportunity to go ahead and raise your hand if you've joined us via Zoom. If you joined us via telephone, you'd want to press *9 to indicate that your hand is raised. And I will just wait a little bit and see if we have anybody. Right now, we don't have anyone, but let's just give them a moment.
See anybody, Sarah?
I don't see anybody wishing to speak. Leslie, did anybody indicate that they wish to speak?
No, ma'am, nothing there.
Great.
All right. So that brings us to the item of adjournment. Motion to adjourn from somebody.
Make the motion.
Move.
Second.
Second.
Thank you. Any opposed? All right. Thank you very much. Really appreciate your perseverance. I think we accomplished a lot today. Thanks to your all cooperation. And the good thing is we are ahead of time. So I like that part the most. Thank you all.
Thank you, Chair.
Bye.
Thank you.
Thank you.
Bye.